In terms of should we be doing broad sequencing of all lung cancer tumors, I mean, there are pros and cons, so I'm going to give kind of a hedge answer of it depends. And I think in thinking about it, you know, in order to really develop a good, effective, targeted therapy for lung cancer, you need to find a mutation or translocation or molecular aberration that's driving the tumor, but you also need to find an equally effective drug that matches that and can knock it down to a sufficient amount where it's sufficiently sensitive enough where these tumors shrink and patients have benefit. So if you sequence a whole tumor, you're going to get a lot of useful information, and you may get some not so useful information. You may get information about certain molecular changes or mutations that don't necessarily drive the tumor growth, but they're changes that are there, and what to do about that in an individual patient, I think, for certain of those changes needs to be worked out. For example, if you look at genomic instability and the rate of kind of genomic mutations and aberrations in non-small cell lung cancer and lung cancer in general, it's a lot higher than in other tumors. So it's really on that end of the spectrum, and then there's other tumors where the genomic changes are much more simpler. So one step is finding, do we have a can we identify a driver mutation or molecular change that's really going to be sensitive? And we've done that with EGFR, ALK, ROS1, and we're expanding that pie of what represents non-small cell lung cancer. There's now HER2 mutations, NTRK, and that's growing more and more, but then it's matching it up with an equally effective drug. And that takes a lot of work to do. And if we have these mutations and changes that we're not so sure about, and we give a treatment where it's not really driving the tumor, where we have other effective treatments, there actually may be a potential for harm. But I think eventually we're going to get to the point where we have the drugs and we've narrowed that pie and we're able to sequence the tumors. I think it's just a matter of time where we're able to fully sequence the tumor, have a good sense of what the drivers are, and then match that to our targeted drug. So that was a long-winded answer, but I would say for now, my approach is I test patients definitely with non-squamous lung cancer for things I know I have drugs for. So EGFR, ALK, ROS1, I've been doing HER2, RET. Like I said, the pie is becoming sliced and diced more and more because that's things I could do something about. If I don't find anything on that initial screen, then later on I say, hey, let's sequence the tumor. Let's see if there are things that can guide towards clinical trials when I think it gets to that point where I think other clinical trials may be of benefit.